And thank you for everyone who joined us on Zoom. And thanks, Dr. Dixon, for accepting the invitation to present today's seminar. We have a very special guest, our very own Dr. Dave Dixon. He is the McFarland Professor, and he is the chair of our department, Pharmacotherapy and Outcome Science. He practices preventive care cardiology at VCU Health, and his research includes hypertension, dyslipidemia guideline adherence and implementation, and pharmacist interventions to improve the management of cardiovascular risk factors. He's also associate editor of JAFA, the Journal of the American Pharmacists Association. He's a fellow of, and the Journal of Clinical Lipidology, and he's a fellow of the American Heart Association, the National Lipid Association, the American College of Clinical Pharmacy, and the American College of Cardiology. Without further ado, I'll turn it over to you. Thank you once again, and enjoy.
All right. Thank you very much for the kind introduction and the opportunity to speak. For those of you on Zoom, can you hear me okay? Can I get a thumbs up or a chat?
We can hear you.
Yes? Okay. All right. Hopefully everybody can see as well. It's so much now that before you give a talk, there's so much you have to do just to make sure all the technology is set up correctly. Okay. So for those of you looking to claim credits, there's some information here, and we'll share this again at the end of the presentation as well. So today's talk is, can pharmacists provide affordable and effective hypertension care in the United States? I am sharing a recent research collaboration that was published in JAMA Network Open last November, and really going to go beyond just sort of the clinical effectiveness of pharmacist interventions and really talk about the cost effectiveness and why that matters. I do have two disclosures to mention. The first is that I have received grant funding as a PI from Boehringer Ingelheim. I'm not talking about any of their products, nor do they make antihypertensives, so I don't think that's necessarily relevant. And then secondly, did receive an honorarium from the George Mason Mercatus Center to support the research that's being presented today. So just like with any presentation, always important to kind of have that level setting of the general topic we're talking about. And hypertension is a disease state that I think a lot of people are aware of. The general public has a lot of awareness about their, why high blood pressure might be important. Yet, it is a silent disease, right? So most patients with high blood pressure are going to have no signs or symptoms. They go undiagnosed for long periods of time. It is extremely common. So if we look worldwide, hypertension affects over 1 billion people in the world. 1 in 5 have their hypertension under control, and it is the #1 risk factor for death globally. It is also the #1 risk factor for disability globally, okay? So we're definitely talking about a major problem. So if we zoom into the United States, we have terrific resources, healthcare resources and dollars. So of course, we must be doing a great job managing hypertension. We're not, right? Far from it. Almost half of US adults have hypertension. If you look at the uncontrolled, so 3 in 4 are uncontrolled and 1 in 3 are untreated. Why is that? You could look at lots of reasons, right? So certainly making sure that we have good access to care, we have clinicians understanding but also implementing evidence-based guidelines, and we have good pharmacotherapy treatments that are generally generic and quite affordable. Yet we are still doing a very poor job of controlling hypertension. We often think about hypertension being a big risk factor for cardiovascular disease, right? So we think about stroke, we think about heart attack risk, we might also think about kidney disease, but we have to think about all of the health problems associated with hypertension. And one that's getting a lot of attention finally would be that related to cognitive decline or cognitive impairment. But hypertension affects other organ systems throughout the body. It's also a leading cause for vision loss. And so, again, when we think about hypertension, we have to think a bit more globally about the problems that are caused by it. So what are we doing to address the treatment gaps and the gaps in care that we have? These are some priorities put forth by the Centers for Disease Control and Prevention, but today I'm going to hone in and focus on one specifically, and that is team-based care. And that is really where pharmacy and pharmacists come into play to helping improve hypertension control. Team-based care for hypertension is recommended by the CDC. There's a great resource guide that they actually created to help pharmacists and pharmacies sort of implement good practice in terms of taking care of patients with hypertension. We have guidelines from our major medical societies, both the hypertension guideline, the guideline for other disease states, emphasizing repeatedly the importance of team-based care, and is actually a Class 1A recommendation in those guidelines. There's also been a recent AHA scientific statement highlighting some implementation strategies to improve blood pressure control. Surprise, surprise, they talk a lot about pharmacists. They take a lot about team-based care. So finally, this is the way. And yes, if you've seen me present before, I almost always include at least one minimum Star Wars reference in every talk. So what evidence do we have that pharmacist-led interventions for hypertension are effective? This meta-analysis is almost a decade old, but I think it still stands true that pharmacist-led interventions significantly reduce systolic and diastolic blood pressure compared to usual care. But importantly, there is a larger effect size if the intervention was pharmacist-led and performed at least monthly. So close follow-up and an intervention, again, that had the pharmacist sort of as the lead healthcare professional. Many of you will remember the 2018 study of the Los Angeles barbershop trial, which honed in on a specific population that's disproportionately affected by hypertension. That's African-American or Black men. This pharmacist-led intervention resulted in almost a 22 millimeter of mercury reduction in systolic blood pressure, almost a 15 millimeter of mercury reduction in diastolic blood pressure. And you can see that the control rate achieved by the pharmacist intervention was significantly higher than the control group. They did do a cost-effectiveness analysis of this study and did find it to be highly cost-effective, but this is a very unique intervention because it was delivered in a barbershop. So it may not be something that we can sort of scale up to the masses, okay? And so keep that in mind as we start to kind of go through the next few slides. So the study that was kind of the clinical or the model foundation, the clinical model foundation for our study was the REACTION trial. This is the randomized trial of the effect of pharmacist prescribing on improving blood pressure in the community. This trial was multi-centered, randomized. The intervention group received enhanced pharmacist care, which is unique because the pharmacists were conducting independent patient assessment, counseling, and prescribing of antihypertensive medications. That's what makes this model unique compared to a lot of the other randomized trials that have been published. The pharmacy practice settings were also diverse, so it included mostly community pharmacists, but it also included hospital and primary care clinics. And the comparator group wasn't your traditional control group. They did receive, it was or considered to be an enhanced usual care because they did receive a wallet card for their blood pressure readings. They received some education, and they did receive blood pressure measurement by the pharmacist at 3-month intervals. And that's not exactly what we call the standard, if you think about, the standard of care. So the usual care group was a little bit enhanced. So what about the effectiveness? The primary results showed that the intervention compared to usual care led to a significant reduction in both systolic and diastolic blood pressure. So there's definitely a consistent theme here. So the authors of the REACTION trial did a cost-effectiveness analysis, but looking at this from a Canadian perspective, they did find that the model was cost-effective. But obviously, it's very limited to Canada, which has a very different healthcare system in that it is all managed through kind of their central government, whereas here in the United States, we have a smorgasbord of different arrays of different players in the healthcare system, right? So you've got the federal government involved, you have state governments, you have commercial, private plans, and it goes on and on. And so this kind of highlights where there are some gaps in terms of what we know about the clinical effectiveness of pharmacist-led interventions, but then also the cost effectiveness of those models. All right, so a couple questions, and then we're going to jump into the study. So if you'll respond in the chat, or if you're here in person, feel free just to shout out the answer. What proportion of US adults with hypertension are uncontrolled? 1 in 2, 1 in 3, 3 in 4, or 4 in 5? I hear a lot of C's. You would be correct. Question 2, which of the following best describes the most unique aspect of the pharmacist intervention used in the REACTION trial? Independent prescribing, education and counseling, prescribing via a collaborative practice agreement, or sending recommendations to the participant's medical provider? Prescribing, yes, independent prescribing, option A. You guys were paying attention. It's good. All right. So now to the research question. So what would be the cost effectiveness of implementing a pharmacist prescribing intervention, underlining that again, to improve blood pressure control in the US? So my colleagues and I used a 5-state Markov model, meaning that there's a finite sort of number of stages that a patient can be in at any given time. Patients were assumed to enter with uncontrolled hypertension and no prior cardiovascular or kidney disease. So we're really talking about primary prevention here. Those patients that develop hypertension maybe at a younger age, and not those that are too weighed down with other comorbidities. The conceptual model, so pharmacist prescribing intervention, we assume would, of course, reduce blood pressure. Blood pressure, particularly systolic blood pressure, is a very powerful surrogate in terms of predicting the risk of cardiovascular and kidney disease. The cost of model implementation was then compared with the long-term cost offsets. So if we reduce blood pressure effectively long enough, we hope that there would be fewer heart attacks, strokes, fewer kidney events. And because we have fewer events happening, we hopefully would lower the overall cost of care. Instead of looking at a short time horizon, we looked at a 30-year time horizon. So we really asked the question of, what if we just turn the faucet wide open tomorrow and we let this run for 30 years to kind of see what the overall economic impact would be? We also assumed a 50% uptake. So about 50% of those patients that would be eligible would actually participate in this model. And then the qualities were discounted at 3%, which is pretty standard. So this is the model structure. So starting at the top left, patients had, of course, whatever their baseline cardiovascular and kidney disease risk was, using parameters frequently used in cardiovascular risk prediction models, such as the Framingham risk score, or the pooled cohort equation. So looking at age, cholesterol levels, BMI, smoking status. And then patients, of course, would flow either into a usual care group or the pharmacist intervention. And the relative disease risk are outlined on the right. And then at the bottom, you can see that patients essentially are going to be in one of these 5 buckets, right? So either alive with no cardiovascular or kidney history. They could be alive, but only have a CV history. They could pass away. They could be dead. And so this kind of gives you a sense of the model itself. So in terms of determining the associated risk over time, for the cardiovascular disease risk, this was estimated using results from the blood pressure lowering treatment trialist collaboration. This is a group that continues to kind of every 5 to 10 years provide an update regarding the impact of blood pressure reduction on outcomes. And they look at multiple large observational epi type studies. There is an analogous group, the cholesterol treatment trialist collaboration, that does the same thing for LDL cholesterol. And then the comparator in this case was estimated kind of based on Framingham risk equations. You might ask, well, why Framingham? That's what was used in the original REACTION trial. And so we didn't feel like shifting over to the ASCVD risk calculator would be easy to do. It could confound the results a bit. And we actually have a newer risk prevention calculator called Prevent. And there are literally dozens of other risk calculators out there, and none of them are perfect. So we decided to stick with what was used in the original trial. Kidney disease risk was based on the risk of end-stage kidney disease, based on the relationship that's pretty much, pretty proven, the relationship between blood pressure and the incidence of end-stage kidney disease. This was pulled from a historical cohort that has a 25-year follow-up, kind of looking at the incidence of end-stage kidney disease in patients and its association with blood pressure. This is, again, kind of a standard data or input that you would use. And then for mortality risk, this was based on US life tables with a hazard ratio of 1.7 applied to account for that increased risk of mortality in a population that has cardiovascular disease. So a bit more about the clinical model structure. So again, the reaction trial, how was it delivered? How was the care delivered, right? These were face-to-face encounters with the pharmacist every 4 weeks until blood pressure was controlled for at least 2 consecutive visits. And then they were followed up at 12-week intervals. This is pretty consistent with our guidelines. Guidelines say that patients should be seen monthly if they're uncontrolled, and then we can reduce the frequency of those follow-up visits over time. In some prior work I've done with some colleagues here, it's pretty clear that one of the big components of these types of interventions and why they work is that close follow-up. It's difficult to manage chronic disease, seeing someone every 6 months, every 4 months, or even once a year. It is those frequent touches that seems to really move the needle. We estimated basically that there would be 6 visits in that first year, and then 4 visits per year thereafter. So patients would continue to be followed in the model. The model base case assumed a mean, or used the mean reduction that was achieved in the trial of 18.3 millimeters of mercury. And it assumed that blood pressure would remain at baseline levels in the comparator group. The population characteristics listed here are those from the reaction trial. There is one key limitation that we'll come back to later, is that this was a fairly homogeneous population from the original trial conducted in Alberta, Canada, so not exactly very diverse or representative of the United States. Outside of that, though, pretty standard in terms of middle-aged individuals, approximately 50-50 between male and female, systolic, diastolic blood pressure of about 150/80. And you can see that a lot of these folks were treated, but then some weren't. High smoking rates, diabetes. So this study had a pretty high prevalence of diabetes. So that's something else to keep in mind. Whereas if you're thinking about, the United States, our prevalence of diabetes, 15% or so, depending on, what reference you look at. So definitely something to keep in mind there. Yes, BMI was an average. So what about the cost inputs? So one thing we did was, when we did the initial analysis, was let's calculate this using what is currently possible on average, realizing that there has been a lot of advancement at the state level in terms of pharmacist ability to get reimbursed for clinical services. But we're still nowhere where we want to be. And in most states, pharmacists are still pretty limited in what they could bill. So we just use the flat level 1 billing code, which again, probably in most cases is the most you can do from a billing standpoint. Antihypertensive medication cost. There's actually a really great study that actually calculated this number. It was published in Circulation, I believe, that we used to input that. And if you're really going to get patients to goal, you're going to have to use more than one medication. So this is assuming patients might be on 3 or 4 antihypertensives. Annual background, all-cause healthcare cost based on age-specific values from AHRQ. Cost of the events there. There was a microsimulation study for hypertension, but there's also the US renal data system that we also used for those inputs. And of course, all costs were inflated to 2021 US dollars based on the Consumer Price Index. So this is table 1 from the paper, and kind of highlighting here the key aspects that I want you to take from this is looking at the difference between usual care and the pharmacist intervention. Basically, there would be 2,100 fewer cardiovascular events with the intervention, 8 fewer end-stage kidney disease events. Kidney's challenging just because there's a lot of competing aspects going on there. The prevention of kidney disease, I think typically is a bit more longstanding. You've got other factors here. You know, if someone has diabetes, how well controlled is the diabetes? So, you know, blood pressure is a part of it, but certainly it's not the only factor. And then per participant, you can see that there's just over a $10,000 decrease in cost. So that's what things look like at the kind of big picture level in terms of events avoided and the cost that are saved. We did do sensitivity analysis. You can see that 100% of the interactions are in the economically dominant quadrant of the cost utility plane. So in that lower right quadrant, regardless of the assumptions made, you can see that it's pretty consistently demonstrating that this intervention, pharmacist prescribing intervention, would be economically dominant. But we wanted to be thorough. So we did multiple sensitivity analyses, realizing that just like with any cost effectiveness study, you're making some assumptions, right? Well, your assumptions could be wrong. So the first thing we did is we said, okay, well, pharmacists now can only bill this certain amount in most cases. What if they could bill what we might consider to be maybe a reasonable amount, you know, that maybe would be acceptable? And so we inputted $100 for that initial visit as kind of like the reimbursement rate, and then $50 for follow-up visits. That's maybe even a little low, but it is certainly more than $23 per visit. We also looked at shorter time horizons, so all the way down to 5 years. We looked at different assumptions for the reduction in systolic blood pressure because, yes, blood pressure is reduced by 18. In one trial, it might be 7 in another, right? It might be 25 in another trial. So we kind of looked at a range of systolic blood pressure decreases. We looked at each type of health benefit specifically. We also looked at the assumption that the hypertension benefit would only be sustained for 10 years. And so there might be some kind of loss of benefit after that. And the conservative scenario in which the systolic blood pressure decrease was assumed to be minus 10, losing 50% of the benefit at 5 years and 100% of benefit at 10 years. So basically, hypothesizing all of the different things that could pan out versus looking at our primary analysis and saying, look, this is amazing, this model works. That's not going to be very convincing, especially when your hope is that this work has some influence at the policy level. So if you look at the incremental cost effectiveness ratios, or ICER, across the board, for all of these different analyses, the intervention either dominates, or you can see that the ICERs are well below the typical willingness to pay threshold. Less than 50,000 would be pretty cost effective. And you can see that across the board here, it's pretty dominant. We also wanted to calculate cumulative cost savings over time. And this is really the wow factor for us because that number came back to be just over $1 trillion. And again, that's assuming 50% of eligible participants receive the intervention and looking at a 30-year time horizon. So certainly that number might be smaller over shorter time horizons. We also wanted to kind of see what events were being avoided the most that might actually explain some of those cost savings. And so without question, reducing the number of myocardial infarction events was really the big driver of the cost savings, followed by ischemic stroke. And as I mentioned before, kidney outcomes a bit more complicated. So kind of a key take home was, again, with a 50% uptake of this intervention, there'd be just over $10,000 saved per person over a 30-year time horizon. if we kind of zoom out and look at this from a population level, that cumulative savings comes in at just over $1 trillion. Some study strengths, implications, next steps. I think by far, this is the most robust cost-effectiveness study. Again, looking at a model that might actually be implementable across the United States. Certainly, there have been other cost-effectiveness studies looking at other models, like I said, the barbershop study. But again, that's not something that's going to be able to scale, but so much. It does provide evidence with the potential to impact both state and federal healthcare policy in support of advancing the role of pharmacists. I think this is especially true at the state level, where we've actually made progress in terms of passing legislation, including Virginia, to at least open the doors, if you will, for pharmacists to be able to bill for certain services. We still have a long ways to go. And then, the goal is that we really are in the process now of obtaining funding to support one of the first really international multi-center trials to look at the effectiveness of this intervention. So have partners in Canada, for example, that we're working on this now, and really trying to pitch this as a solution to address some of the implementation barriers, but also addressing racial and ethnic disparities in hypertension outcomes. The data is pretty clear that we have a huge gap there. We have gaps across the board, but particularly in underserved communities, certain minority groups, and we feel like that this type of model could be an effective tool. No study's perfect. So I think this is probably one of the first reviewer comments that we saw was that 50% uptake is ambitious, and yeah, it could be. However, if there's an adequate reimbursement structure in place, if we could flip that switch today with all the services and the activities that a pharmacist can do legally through their scope of practice, I think the uptake would be pretty high. And we kind of tried to make the argument that a 50% uptake could be an underestimate if the appropriate structures were in place to permit pharmacists to really do this. We also assume that the blood pressure control would not change in the comparator group. And our rationale for that is, if you look at the data, it is very clear that blood pressure control in the United States is getting worse. One of the big drivers of that is COVID-19. It's still having its impact, even though we're not quite where we were in March of 2020. It's still having an impact. The prevalence of hypertension is also increasing. We have an aging population. We have a younger middle-aged population that, lifestyle-wise, we've got some room to improve. We'll phrase it that way. One of the big drivers of developing hypertension is obesity. Yet we have rising obesity rates. So we felt comfortable just kind of making this assumption that once you balance everything out, that there would simply be no change over time in that comparator group. It's also important to recognize that the findings cannot be generalized to other special populations with pregnancy, with hypertension, such as those who are pregnant. It's also unclear how other delivery models, so thinking about like telehealth, which we're using more now, telemonitoring of blood pressure, how that might impact cost effectiveness. And then, as I mentioned before, the demographics of the reaction trial participants, not really generalizable to the United States. With that said, we do have several randomized controlled trials in underserved minority groups showing that pharmacist interventions are quite effective at improving outcomes. So, but that is still kind of a limitation of the study as well. So question 3, which clinical outcome did the cost effectiveness study show was most avoided by the pharmacist intervention over time? D. Man, you guys are smart. Which of the following is the major barrier to implementing a pharmacist-led model for hypertension in the United States? Is it a lack of pharmacists, a lack of evidence supporting cost effectiveness, a lack of evidence supporting clinical effectiveness, or lack of reimbursement for clinical pharmacy services? Good job. You guys are paying attention. So really important to thank my collaborators. Carissa Johnston, who's the principal and scientific director at Broad Street HOR, who did yeoman's effort to kind of pull this model together and create the beautiful figures as well. Julie Patterson, who may sound familiar to a lot of you, who was on faculty here, but is now the Senior Director of Research at the National Pharmaceutical Council. And then Carly O'Mara, who is the Dean Professor in New Zealand at the University of Otago there, who is very much involved in the original reaction trial. And then Ross Suzuki, who is Professor and Chair at the University of Alberta, Canada, and was the principal investigator of the reaction trial. And as with any kind of clinical trials, it takes participants. Without participants, there is no trial, there's no data. There is certainly no cost-effective study. So I always like to acknowledge those individuals that participated in the original trial. And then lastly, the Mercatus Center, who provided some support. And with that, I will take your questions. Thank you. Use the mic if you, there should be a mic nearby. Thank you.
Okay. First of all, thank you so much. And I just have a question about the reimbursement rate. Is it fixed for now, or it depends on the time that the pharmacist spent?
It's a good question. So is the reimbursement rate fixed or based on amount of time? So, you know, generally speaking, pharmacists in most cases aren't necessarily billing for any service, although again, there's a lot of change happening there. The level of the visit and therefore the level of reimbursement is a combination of the complexity of the visit and time spent. With that said, I think a lot of you know, my physician colleagues would tell you that quite often they're needing to spend more time than what's associated. So a level 1 visit, you know, you're looking at maybe 5 or 10 minutes at most. Single disease state, low complexity. Well, in most cases, that's probably, or not probably, it is an it's under billing, under coding, if you will. Because a lot of patients that have uncontrolled hypertension, by the time you're going through lifestyle modifications, you're modifying drug therapy, you're monitoring, you're going to spend more than 5 minutes with that patient. The $23 that we use as the input was a fixed amount because that is the max that you can get at that level 1 visit code, if that makes sense.
This is going to the insurance companies, right? And they reimburse the pharmacists, but how about the like uninsured people, or if they do not have insurance, do they have to pay it out of pocket?
So the uninsured population was certainly not kind of factored into this. And while we certainly continue to have an uninsured population in the United States, it's definitely much smaller than it was before implementation of the Affordable Care Act. So, you know, in someone that's uninsured, generally you're going to be referring them to other kind of federal or state resources, hoping they can try to get on Medicaid. There are still active functioning free clinics as well. So crossover, where we have, you know, faculty that practice and provide services there. And then the billing piece is kind of removed because it's more of a service provided to that particular community. Yeah, good question.
Thank you.
I think there's a question in the chat. How can you use the, excuse me. Hi, Starlin. How can you use this to set up the CDC, CBD blood pressure state grants to mirror your method, or can you assist us in using this model at that level forthcoming? The short answer is, yeah, let's chat offline. Love it. And that's, you know, that was really our hope, is that this would help support efforts, especially at the state level, because that's really where we're gaining traction in terms of not just advancing scope of practice, but also advancing, you know, reimbursement for pharmacy services. And, you know, at the end of the day, I always like to, you know, put this out there. Like, this is not a matter of pharmacists getting paid more. And this is a message that sometimes gets put out there. It's really just getting paid for the work that we already do and have been doing for a very long time. So, other questions? Yes.
Sort of going off of Rana's question from earlier, I'm kind of curious, back with that reaction trial, how pharmacy services were covered for those patients, just kind of thinking about if there's anything that we don't currently have in our healthcare system and just how pharmacists provide services, the work that we already do, how that kind of compares to the pharmacy services that were reimbursed and covered in the Canadian health system.
Okay, good question. So how was the participant visits kind of covered? So the trial would have covered that as part of the study. With that said, Alberta, they do have prescriptive authority in that province, but in most of the other provinces in Canada, they don't. So they struggle with some of the same issues. And then despite that scope of practice, the Canadian government may not necessarily, reimburse for that service. And so that was another reason to sort of, do this work. And so even in a, kind of a federalized national healthcare system, doesn't necessarily mean that, they're just reimbursing for all services provided. There is still that ask of the evidence, which is a little bit unfortunate in a way. I mean, if you think about other professions, I don't feel like that they've really had to provide evidence of effectiveness of what they do, in the same way that pharmacists have had to really kind of slog away at providing that. And, we have the evidence. I'm not saying there aren't more research questions, because there are. And that's where, again, we wanted to focus on the cost effectiveness aspect, in hopes that, it would generate interest beyond just the clinical outcomes, in helping to persuade our legislators to kind of open up some change as it relates to reimbursement.
And hopefully it'll help us figure out how to justify hiring new pharmacists or additional staff, because this may not necessarily even be stuff that we already do. It may be stuff we barely even have time to do and because of the way that it's billed at level 1, it's hard to maybe calculate the FTEs for an additional pharmacist on staff.
Yeah, and it's difficult to shift when there's so much, we still need to get the right drug to the right person at the right time. Like that still needs to happen. But then we also, there's this other side and this opportunity. And so it's kind of, innovation's hard. Change is hard. And I think as a profession, like especially here in the United States, like we have a lot of hard times ahead because there's going to be a lot of change. I think most of that will be positive change. And it's going to take some time to get there.
Thank you very much for your presentation.
Dave, can you hear me?
I can.
So at the current compensation, this does not seem to be sustainable. If you're going to try to convince pharmacists in Virginia to do something like this, let's say we've got prescriptive authority, what argument would you make for them to do this, even though they would be losing money each service event they would be providing?
So, but using the current available reimbursement, is that what you're saying?
Yeah, so I'm trying to figure out, so, I'm all about the business model, sustainable business models, and it's not sustainable. But, to get somewhere, sometimes you just have to start and work toward a final goal.
Right.
But if you don't get pharmacists doing it, it's hard. It's like a catch-22. I don't get paid enough,
Right.
so I'm not doing it. And so
Okay.
what would you suggest if you're going to try to convince pharmacists to implement something like this? What would you say?
So I think you have to go a step above the pharmacist at first. And I think at least currently, it really comes down to quality care models and kind of the reimbursement related to healthcare quality. Right now, the quality measure for hypertension is the last recorded blood pressure in the calendar year. And so I think partnership between pharmacies and whether it's health systems, maybe even preferably payers, to sort of address the lack of quality in terms of hypertension control is how you kind of can get around that loss of reimbursement, because you can kind of make up for that by improving the quality. And then obviously some of those dollars saved should, in that business model, then flow back to the pharmacy and the pharmacists that are providing the care. And so then when you're going to that pharmacist and saying, hey, we need to do this, then I think that's an easier conversation. I'd also add that, the part of the process at the pharmacy where we get the right drug to the right patient at the right time, I think that's where, advancing the role and the training of our technicians becomes important to, really carry the bulk of that workload so that the pharmacist is actually freed up to do these things. Because I agree with you 100% that, in Virginia, we've passed a lot of legislation over the past years to advance scope of practice, statewide protocols for all these things, and that's great. But there was no requirement that the payer actually reimburse the pharmacy or the pharmacist for doing that service. So as you can imagine, the uptake of those services is going to be pretty minimal. We've made some progress with the legislation that now requires, Medicaid to kind of pay pharmacists for services that they provide. But even that's limited, and we're just, figuring that out. So to answer your question, David, I would definitely think about those quality care models and those kind of partnerships as it currently stands, because I agree that the uptake of this is going to be low without that reimbursement. Does that answer your question?
Yeah. Are you familiar with any specific institutions in Virginia that might be amenable to that?
Yes. Yes.
Can you share or not?
I mean, I think certainly, I think there's emerging opportunities here locally. I would definitely put Bon Secours on that list. And then I would also probably put Korean Clinic on that list.
But not VCU Health System?
No, I said locally, VCU.
Oh, okay,
I think there are emerging opportunities.
Thanks.
Good comment here too about a big push for governments to use community health workers. So pharmacists could be supervising their use. Yeah, and this is, I think it's going to be interesting to figure that out. I do think community health workers can play a role. I think there's definitely some evidence. A lot of that has to be managed at the local level though. And then who's managing that? So yeah, I think that's where public health departments, local health departments have to play a big role, and maybe the pharmacist fits in there somewhere, but okay. Derek, see your hand up.
Sure. So I was going to sort of ask a follow-on to David's question, which was this analysis would seem to lend itself very well to value-based care reimbursements, whether that's in the Medicare Advantage space or the self-insured commercial population, as opposed to trying to hunt down CPT codes for maximizing visits.
Right.
Is there a appetite or easier strategy to go after the value-based care and managed care settings that I think haven't really been done super well at the physician level at this point?
Yeah, no, I think you're completely right. The other thing I'd add is not all healthcare systems have shifted over to that value-based model either. VCU in that mix, which makes it challenging to kind of have that, to make that argument in particular. But no, I agree. And my concern with while it's billing per encounter is nice, I don't think it's optimal long term. If I look at my physician colleagues and others that are in a fee-for-service model, they're running visit to visit, right? And to me, that's part of the problem with chronic disease is there's not enough time and not enough touch points. And so, if we as pharmacists get tied up in that same fee-for-service model, do we kind of become the same way where, you know, we've got 5 or 10 minutes to talk to this patient with uncontrolled diabetes, hypertension, and everything else? We're no different. And so I think that's where these models have been successful, is that the pharmacist has the time to actually spend to unravel the medication issues. And then to your point, Derek, you know, that's where I think the value add really is, and what makes us unique in the skill set that we have compared to other healthcare professionals. So definitely agree that the value-based approach makes the most sense, especially with hypertension, where we have a very clear surrogate marker, a very clear kind of goal or target that we're trying to reach. It makes it a lot easier to demonstrate that value.
I have a question. Has to do with the simulation, the cohort simulation. So what was the starting age of the simulated cohort? I'm assuming it's mirroring what's from the randomized clinical trial, but
Correct.
was it 63, 64 years old?
I want to say we used 40, if I'm not mistaken.
40?
Yeah.
Okay. So, but the trial median age
That was the
was, okay. I was asking this because,
Thinking 30 years, 40 to 70.
okay. Yeah, because I was thinking if we're simulating 60 onwards, we're assuming patients live
Right.
until 90.
No.
But at the same time, this would make, if we're simulating a younger cohort,
Right.
then the savings are much more significantly the.
Right.
Okay.
Yeah.
The other question that I had to do with any intervention that potentially saves 25% of the entirety of US healthcare expenditure, which is what this.
Mhm.
So just for context, the United States spends $4 trillion in healthcare every year. So an intervention that saves a fourth of that is it's not a drop in the bucket. It's a significant change. So if we were having this conversation from the industry side, we're like, can we maximize pharmacist reimbursement to keep things as they are?
Right.
And so it would be an interesting post-hoc analysis to see
Sure.
how could we maximize, obviously, alluding to Dr. Holford's question about making this sustainable.
Mhm.
That post-hoc analysis would actually say, how much can we spend how much can we compensate pharmacists for their actual work while keeping the savings component to this intervention?
Yeah, I think that's a great point. And sort of like, what is that, max willingness to pay type of approach of what is that? The numbers we used mirror, I think, a little bit more of what the typical payment might be, but definitely agree that that would be a good, interesting analysis to do to figure out what the max is. Because yeah, it could be, much different than that. Yeah, awesome.